Alright, so welcome to the lecture on opiate drugs, use and adverse effects. So we're going to consider two sections. One, the use of opiate drugs, and then the adverse effects and abuse of opiate drugs. In the first section, we'll look at the history, we'll look at the overview of different types of receptors, and then the different classes of opiate drugs. And then in the second part, we'll look at the side effects of these drugs, and then the problems of tolerance and dependence. So what is narcosis? This refers to a drunken or sleepy state. But when we hear the word narcotics, usually it means abused substances like cocaine, or even like the police has an anti-narcotic squad. But for pharmacology, we say that narcotics means drugs of the opiate group, which are mostly strong analgesics. So now let's look at the historical development of opiate analgesics. The poppy plant has been known for a long time. Since from the 350 BC, Greek historians have described getting poppy juice, which can be used as a hypnotic. It puts people to sleep. When you take the fluid out of the poppy seeds, that is called opium. And opium can be dried into a gum or made into a powder. So poppy plant has been used medicinally by Egyptians, Greeks, and Romans. In 1806, the first chemical was isolated out of opium, and it was called morphine. Comes from the word Morpheus, which means the Greek god of dreams, the god that comes to you in your dreams, because morphine can make people sleepy. And in 1832, the second chemical, codeine, was isolated, and now we can isolate at up to 25 different alkaloid chemicals. In 1874, we have the first synthetic molecule, which is synthesized from morphine, and diacetylmorphine, which is called heroin. And in the body, heroin is converted back to morphine. Up to the 1900s, opium was used everywhere. You could use it, you could smoke it, you could put it in various medicines. It was only in 1914 that the Narcotics Act was passed in the US that prevents widespread use of opium. You need a prescription from doctors. And now there's international agreements to limit the growth of poppy plants, and that's why you don't grow poppy plants in your garden. Currently, Afghanistan is a country that supplies most of the world's illegal opium, which is used to make heroin. The second top supplier is Burma or Myanmar, whereas the legal suppliers, most opium come from India or Turkey, where it is grown in order to be used for isolating morphine. In terms of terminology, opiate refers to all the alkaloids you can get from opium, the opium plant, like morphine, whereas opioid is a bigger term that covers all substances that binds to the opiate receptors. It doesn't matter whether that substance is natural, is from the plant, or is synthesized in the laboratory. And now the opiate receptors. So in the 1970s, it was found that opiates actually bind to different types of opiate receptors. There are at least 3 types of opiate receptors: mu, kappa, and delta, and each of these has their own subtypes like mu1, mu2, and so on. For the important opiate drugs in medical use, most of them are mu receptor agonists. A few are kappa agonists. And opiate receptors belong to the class of receptors that we call G-protein kappa receptors, where the activation of the receptor leads to the activation of intracellular G proteins, leading to signal transduction pathways to cellular results. Now let's consider the synthetic opiate drugs. So in the 1940s, the drug pethidine and methadone was synthesized. Pethidine is also called meperidine in the US. And then in the 60s, antagonist drugs was developed. And these are Naltrexone and Naltrexone, which are mostly mu receptor antagonists. And then in the 70s, opiates was developed which had a mixed agonist and antagonist action, like nalbuphine, which is a mu antagonist but a kappa agonist. And then in the 1980s, there was a partial mu agonist developed called buprenorphine. Also in the 1980s, it was discovered that our body had their own opiate chemicals, and this endogenous opiates was called endogenous opiate peptide, or endorphins. So these endorphins have affinity, they bind to the opiate receptor, and there are 3 families of endorphins: the enkephalin, endorphin, and dynorphin. And these chemicals are released during stress or pain, and they will provide the endogenous pain-killing effect, and they are released also after we take or inject opiate drugs. So now we're going to consider the different important opiate drugs one by one. We'll start with the full or the strong agonist, moving on to the partial agonist, and then the mixed agonist-antagonist, and then antagonist, pure antagonist, and finally some other opiates. So let's start off with the full agonist or the strong agonist, and we're going to consider 4 of them: morphine, methadone, pethidine, and fentanyl. These drugs are used mostly for analgesia, and some are used for anesthesia. So the most important use for these drugs are for analgesia. These are for severe pain, not minor pain, chronic pain, severe pain like cancer pain, or very acute pain like after an operation, or during labor, or after the patient had a myocardial infarction. Mechanism of action. So these are mostly agonists, strong agonists of the mu receptors, and then they will activate these mu receptors on neurons both inside and outside of the central nervous system. So they activate the mu receptors, and they also cause the release of the endorphins, which can then bind other receptors. And so at the we're talking about the opioid receptors at the spinal cord, at the cortex, and the brainstem. And there, the activation of these receptors can inhibit the release of excitatory neurotransmitters like substance P or histamine, and also they can inhibit the spinal cord dorsal horn pain transmission neurons. So there's a lot of opioid receptors on the neurons at the dorsal horn, and this activation of opioid receptors will inhibit the pain transmission signaling, and the result will be that the patient does not feel the pain, although the patient is still conscious. Right, now we're going to consider the different routes of administration. So if you talk about the oral routes, there's tablets, liquid, and if it's a parenteral, it can be given IV, subcutaneous, intramuscular, and also there's a type of administration called patient-controlled analgesia, where the patient is hooked up to the subcutaneous infusion machine, and if the patient feels pain, he can just click and receives an extra bolus of the drug whenever there is a breakthrough pain. And then parenteral, there's also intraepidural. You can deliver the drug into the epidural space for that regional application, or the drug can be given by way of suppositories into the rectum. And then there is the transdermal patch for drug fentanyl. So this is where you stick the patch on the skin and the drug will enter the skin. And the advantage is that you do not inject the patient, and also it's advantageous for those who cannot swallow, but you replace something like once every 72 hours. Right, so these drugs can be used for analgesia. Now we'll briefly consider anesthesia. So for anesthesia, opiates can be used as a pre-med. So it's part of the mixture of sedatives, anxiolytics, and analgesic component given before anesthesia. Or it can be used for regional anesthesia, like into the epidural space of the spinal cord, so that there's less side effects compared to systemic administration. Or it can be part of the primary anesthetic regimen, which is for keeping the patient unconscious and also providing the analgesia. Like for example, fentanyl is an opiate which is mixed with muscle relaxants and other inhalational anesthetics. Okay, now we're going to discuss briefly that the fact about the opiate drugs actually need to be kept in a secure way in the hospital, because it is subject to being stolen for abuse. So most of these drugs called controlled drugs are kept in the dangerous drugs cupboard, and the key is held securely by the senior staff in the ward. So now we'll go through the drugs one by one. So starting with the full or strong agonist, the first one is morphine. Morphine is probably the most important opiate you have in the hospital. It is the most common opiate analgesic and used for moderate to severe pain. And it is a drug of choice for cancer pain, which is often very serious and used for long term. Palliative care, where the patient cannot be healed and the pain is just present all the time. And morphine can be given orally, parenterally, syrup, suppository. And the next one is methadone. Methadone is a synthetic drug, but it's equally efficacious as morphine. But one difference is that it has a long half-life, and that allows for less frequent dosing, but then it takes longer to achieve the steady state levels. And therefore it is not suitable if the pain is rapidly changing, because it takes time to reach its maximum level. So it's more for chronic pain that is stable, not changing. And later we'll see that it can be used as a replacement opiate in the treatment of heroin addicts. And then the next one would be pethidine. Again, this is a synthetic drug, and in the US it's called meperidine. This is again, in terms of efficacy, comparable to morphine, but the difference is that the onset is faster and the duration of action is shorter. So here's a drug that can work very fast, and it stops its action fast as well. It cannot be used for the long term, because if it's used longer than 48 hours, the metabolite called normeperidine is actually toxic. It can cause seizures, and so it's not used long term. So it's quite suitable for acute episodes of pain, such as labor pain. And the next one is fentanyl. Again, another synthetic drug. It has a very fast onset after IV administration, because it's lipid soluble, and therefore it is commonly and used in anesthesia. And as we said earlier, this drug is also available as a transdermal patch. So then this is useful when the patient cannot swallow, but because the drug enters through the skin slowly, it takes a long time to build up to a high levels in the fat, subcutaneous fat, in order to reach the optimum level for control of pain. And so this is only suitable if the pain is chronic and stable, and it is not for patients with a very acute and changing levels of pain. And now we're going to consider a strong agonist, which is mostly used as a drug of abuse, called heroin. And heroin is known by many slang names, brown, China, and over here it's sometimes called ubat or bifan. And it's derived from morphine, but it's much more potent, and it is really a major drug of abuse in this part of the world. The reason why it is abused is because it's works very fast. That's because the drug is very lipid soluble. So once you inject the drug, it enters the brain very fast, and it converts quickly to morphine. It binds to the brain opioid receptors, so you can get an effect even in about 7 to 8 seconds after an IV injection. And it can be given in other ways, like smoke snorted through the nostrils, and it is a very high abuse potential and prohibited in many countries. Now we're moving on to the partial or moderate agonist. So the first one is codeine. Codeine is available in many countries, especially in cough preparations, but it's not available here. But this preparation is available, which is Panadine, paracetamol plus codeine in one tablet. So codeine is actually a moderate agonist. Partial agonist is less efficacious than morphine, because it has a lower affinity for the opiate receptors. And also much of its activity could come from its metabolite, codeine 6-glucuronide. You can see here that the 6-CG is the main metabolite. And so codeine is used for moderate pain. As I said, it may be combined with paracetamol in the preparation called Panadine. The next one is buprenorphine. Buprenorphine is a partial agonist of the mu receptor, but it also is an antagonist at the kappa receptor, an agonist at the delta receptor. But its analgesic effect comes from its partial agonist at the mu receptor. It is used as an analgesic, and then it is formulated as a sublingual tablet, because it is undergoes high first pass metabolism if swallowed orally. So therefore it is formulated to be placed under the tongue. In the third category, we have another drug which has a mixed agonist-antagonist profile, and the example is nalbuphine. Nalbuphine is an analgesic by way of being a kappa receptor agonist. It is a mu receptor antagonist. The advantage of that is that it does not have the side effects of mu receptors, such as respiratory depression, nausea, and vomiting. It uses its kappa receptor agonist activity for analgesia, although kappa receptors can lead to some side effects such as dysphoria. And this is a drug that's used as a for mild to moderate pain. That is because it has a ceiling effect. There's no additional effect after a certain dose, so it's more for mild to moderate pain. Now move on to the fourth category, which is the antagonist drugs. And the first example is naloxone. Naloxone has a high affinity for the mu receptor and lower affinities for the other delta and kappa receptors. Naloxone being an antagonist with no agonist activity, it has no effect by itself at standard doses. So its major use is to block the opiate receptors, such as during overdose of opiate drugs. So this would then block the receptors and prevent the excessive effects of opiate drug in overdose. But consider what will happen if you were to give a naloxone to a patient who has pain and who is taking morphine. He has pain, he's taking morphine, and he doesn't have pain anymore. What will happen if you give him naloxone? And similarly, we can ask ourselves, what will happen if a patient is taking morphine and is having side effects of morphine, and now we give naloxone? What will happen to that patient? So these are questions to think. If a patient is already taking morphine, which is a full agonist, and experience the effects of morphine, the full agonist, if you add another drug, which is an antagonist to the mu receptor or a partial agonist to the mu receptor, then you're going to cause a reduction in the effect of morphine. Reduction in the sense of a loss of the analgesia or a loss of the side effects of morphine. And the last group is opiates used for other purposes. For example, one of the effects of opiates is to slow down the peristaltic activity of the intestine, and that makes it gives a side effect of constipation, and also it makes it a treatment for diarrhea. So diarrhea has been treated in the past by using opium or other opiate drugs. Also, opiate drugs are able to have a cough suppressive effect to stop coughing. It acts on the opiate receptors in the central nervous system that affects the cough center. So opiates such as codeine has been used for coughing. And now we come to our second major section, which is to consider the adverse effects or side effects of opiate drugs, including abuse of opiates. So we'll start with the side effects, and then we consider the topics of tolerance to opiates, dependence on opiates, and lastly a little bit on addiction to opiates. We'll start with euphoria. Euphoria is that sense of well-being, like a floating sensation, freedom from anxiety, feeling disconnected from reality. And so this produces a very high mood. But when this goes away, the person goes down in the mood. So there's a high-low mood swing. This side effect is rare in those who receive opiates medically for pain, but this is the side effect which is a major contributor for opiates being drugs that is abused. And so there's two components to it. Initially, there is something called rush, which is a very intense feeling that lasts for 1 or 2 minutes, and this is followed by a longer period called high, in which the person feels warm and becomes indifferent to what's happening around them, and this lasts for several hours. And some possible mechanisms for euphoria has been suggested that opiate receptor activation leads to reduction in GABA signaling, and this allows a resultant increase in signaling from dopamine receptors in the nucleus accumbens, that's part of the limbic system structures that affects emotions and mood. So it could be that there is finally an increase in dopamine signaling, which is the neurotransmitter that is involved in rewards. Another side effect is dysphoria. In contrast to euphoria, dysphoria is like the opposite, where there is uncomfortable and mood, and with anxiety, confusion, maybe nightmares. And then miosis is another side effect that is characteristic of opiate drugs. The pupil size is very small, and this can be used to differentiate between a unconscious patient due to opiate overdose compared to other causes. So miosis is another sign of opiate drugs. Respiratory depression is a very important side effect because it can be fatal. So opiate drugs inhibit brainstem mechanisms for respiration. So those patients with impaired lung function may not do well with opiates. Another side effect is sedation, drowsiness, and sleepiness. This is especially prominent in the early stages because later on, patient would develop tolerance to it, as we will discuss later. Nausea and vomiting is yet another side effect of people taking opiate drugs, and this can be very severe. It is a central effect where the opiate receptors trigger the part of the brain that controls vomiting. And but again, this side effect can go away when their tolerance is developed to the drug by the patient. And pruritus can happen. It is likely due to a central effect where activation of the central opiate receptors cause a change in the neurotransmitter release in the spinal centers. And the patient can be treated by giving him an antihistamine, or else switch to a different opiate. And then there are other adverse effects such as bronchospasm and hypotension, and this is due to histamine being released from mast cells, resulting in the lower blood pressure and all that. And it actually resembles anaphylactic shock, and so this is yet another side effect of opiate drugs. Another side effect is constipation. That is because opiate receptors being activated in the gastrointestinal tract will cause a slowing of the gastric motility, as well as reduction in intestinal secretion. So this causes the feces to become drier because they stay longer, and water is reabsorbed from them for a longer period of time. And so this dry feces then causes is constipation. And so therefore patients taking opiates often have to take laxatives because this side effect does not go away over time. When a patient is taking opiates for a while and the opiate levels has reached steady state, then they continue to have analgesia and they also have constipation. This doesn't really go away. However, when they're first taking opiates and the levels is rising with increasing doses, at that time when the doses are rising, they tend to get the side effects such as sedation, nausea, vomiting, respiratory depression. After a while, when the levels have tapered off, stabilized, then these side effects tend to reduce, but the analgesia and constipation still remains. Well, next we are going to consider the topic of tolerance and dependence. All opiates can lead to tolerance and dependence, and especially those strong agonists. What is tolerance? After taking opiates for a while, the body adapts to it. Essentially, the number of receptors gets reduced, and this means that to get the same effect, the patient has to increase the dose. This occurs usually after a few weeks of continuous dosing. You may find that increased dose is needed to maintain the same effect, so that when in a patient who is non-tolerant originally may only need a small amount, which will be too much. The patient may get side effects like respiratory depression. But if that patient gets tolerant to the drug, they may need a much larger amount to even have relief from pain. But tolerance to the analgesic effect is less common. So, and the other factor is that if you're giving this drug to cancer patients who need to take it for a long term with severe pain, they tend not to get tolerance, they tend not to need increasing dose over time. So we are able to prescribe these drugs to cancer patients without worrying about having to increase dose over time. Tolerance occurs to the many different side effects or effects, analgesic effects, sedative effects, emetic, euphoric, but tolerance does not develop to myositis or constipation. So over time, patient will still have myositis, will still have constipation, even though they no longer really suffer from sedation and vomiting and euphoria. Some side effects develop very fast. Tolerance to them develop very fast, such as sedation and nausea over days. But for other side effects, it takes longer time to develop tolerance, like respiratory depression or euphoria. To get tolerance to those, we need days and up to weeks in time. And then there is cross tolerance. If the patient is having tolerance to morphine and you need a bigger dose to get the same effect, then if that patient changes to methadone, the patient also will need a higher dose of methadone than usual to get the same effect, because once you are tolerant to one opiate, there is a cross tolerance to other opiates as well. And now we're moving on to the topic of dependence. There are two types. We're going to see the first type, which is physical dependence. This occurs after giving the same drug for about 1 to 2 weeks. So physical dependence is when the body gets used to the drug, and if you suddenly remove the drug, then a lot of things go wrong with the body, and the patient will get what is called a withdrawal or abstinence syndrome. So this can be seen if you were to give an antagonist to a patient who is already used to having an agonist. You give an antagonist, suddenly you lose the agonist effect. Within 3 minutes of injecting the antagonist, the patient begins to have a withdrawal syndrome. Or else, if the patient is on oral opiates for a long time, is already having physical dependence, and then if you suddenly remove the dosing and stop giving the tablets, and 8 to 10 hours after the last tablet, a patient will start to show the withdrawal or abstinence syndrome. Patient will experience things such as watery eyes and runny nose, yawning, sweating, cannot get to sleep. The patient would really want to ask for the drug in order to relieve these effects. And if the patient does get the drug, then all this goes away. And symptoms get worse in about 48 to 72 hours if the patient still does not get the drug. And in that time frame, a patient feels restless and irritable, cannot eat, cannot sleep, and they get bumps on the skin called goose flesh, and that is why this is sometimes called cold turkey, because that's how the skin of the turkey looks like. And they get diarrhea, and they get a body ache, and they may feel very depressed, and so this is a very, very difficult time for the patient for the 48 to 72 hours. And finally, if they can last this long, in about 7 to 10 days, all these symptoms disappear. And so we do not want patients who need to take opiates to get into physical dependence, to get into the withdrawal syndrome, because it is a lot of pain for them. So we want to make sure that patients who are having strong agonists, we do not want to give an antagonist or a partial agonist or a mixed receptor agonist antagonist, because that would take the agonist effect away, and the patient may start to get withdrawal syndrome. But what if you want to stop the drug? The patient is not to continue with this drug. Then if you want to avoid withdrawal syndrome, you want to stop the drug gently, slowly. You taper it down. You do not suddenly stop. So you can reduce the dose by 50% for a few days, and another 25% for a few days. Slowly let it go down slowly, and then the patient will probably not experience the withdrawal syndrome. Although if they need the drug, then once you stop the drug, the pain may come back. So once the patient has stopped the drug or when there's no withdrawal syndrome is over, then the patient is back to original state, then if the patient is given that drug again, there's no more tolerance. You can give the patient at the standard dose. You do not have to give it at a very high dose, which was necessary before when the patient was tolerant. So after withdrawal syndrome is over, the patient goes back to the original state, and if they start the drug again, you can give it at a normal low dose. And now we're going to consider the second type of dependence, which is psychological dependence. Now, physical dependence is over by 7 to 10 days, but psychological dependence lasts for weeks and months. So this is sometimes called addiction or craving. So there is a complex neurological changes occurring such that for weeks to months after the patient has stopped the drug, the patient still has this craving and thinks and talks about the drug. He feels the urging to have the drug, and he's forced, compelled to use the drug, and then therefore, if the patient is trying to stop taking this drug, there is a strong tendency to go back to the drug because of this craving and this compulsive use, and this will go on for weeks to months after the drug has stopped and after the physical dependence is over. And this is, however, quite rare for people who need to use opiates for pain, like cancer patients. So for cancer patients, they tend not to get into psychological dependence. They get physical dependence because if you stop the drug, suddenly they get the withdrawal syndrome, but they tend not to get psychological dependence, being having the need to come back to the drug. Don't really get that if you're giving opiates for pain. Now, we do not want our patients to become psychologically dependent because there are many dangers of addiction. As you know, people who are addicted, they suffer from a lot of problems because they don't take care of themselves, and drugs that get illegal drugs can be poisonous. They need high doses because they are basically tolerant, and if you inject drugs with non-sterile needles, you get a lot risk of infectious diseases, and pregnant women can get a drug crossing the placenta, and people resort to crime in order to pay for the drug. So we do not want patients to get into an addiction. So we want to find ways in which we can minimize our patients getting psychologically dependent on opioids. So there are three things we can do. First, we can consider using non-opiate drugs such as NSAIDs instead of opiates. Or if we want to use opiates, we could use opiates that has less withdrawal symptoms, meaning the not using the strong agonists. Second, we should start only at the lowest effective dose and not at the high dose. And lastly, we want to keep on reviewing to make sure that we stop using the opiates the moment the patient don't need it. And so with all this, we try to minimize the risk and the chance of falling into psychological addiction, psychological dependence. So now we're going to consider the next topic, which is if a patient is an addict, what are the ways in which we can help them to be treated from the addiction. And one of the important programs or method has to do with what is called an opiate replacement therapy or program. And the most common one would be to use methadone in place of another opiate, usually heroin. And so let's discuss the methadone program. So our aim is to switch the patient from heroin into methadone, and that is basically detoxification. Detoxification is a process of allowing the body to get rid of a drug while we manage symptoms of withdrawal. So this is trying to help them to stop taking a certain drug but without suffering from withdrawal syndrome, and this will be the first step in the drug treatment program. So the aim of the methadone program is to get an addict off illegal opioids like heroin, and yet without withdrawal syndrome, without getting into euphoria, dysphoria, mood swings, and we do that by switching them to methadone as a form of opiate replacement therapy. So the patient must come to the clinic every day, once a day, to get his methadone. He returns every day for one dose of methadone daily. And now we want to ask, why is methadone such an appropriate drug for this purpose of replacement therapy? Well, we're going to consider some features of methadone, and we want to think for ourselves, why is methadone suitable? Well, the first feature of methadone is that the mean half-life is fairly long. It's about 22 hours. So methadone has a fairly long half-life. And so how does that make methadone suitable for the replacement therapy? The second feature of methadone is that it does not have serious side effects like effects to the cognitive functions. Its side effects are mainly minor, such as euphoria, sedation, rash, and these can reduce with tolerance. So if patient can get tolerance to euphoria, how does that make methadone a suitable drug? And the third feature of methadone is that there is cross tolerance to heroin. So if patient is taking a high dose of methadone because he is tolerant to methadone, then he gets the same tolerance to heroin as well. And the fourth feature is that if methadone is stopped, then the withdrawal symptoms are less severe than heroin, although it is longer, more prolonged, but it is less severe than heroin. So these are features which we need to think for ourselves. Why is it that methadone is suitable for the opiate replacement therapy? So now we're going to summarize the advantages of the methadone program as well as the disadvantages of having this methadone program. But first, the methadone program has been a great advantage because now the drug addict, the heroin addict, do not need to go to the street to buy illegal drugs. So he does not need to find the money, he does not need to be exposed to the risk of toxic drugs and getting wrong doses and getting infections from the needles. And second is that because patient is still stabilized on the methadone, so the patient is able to go back to work. So that would be the advantages of doing the methadone program. But then there are disadvantages as well. The first disadvantage is that the addict is still dependent on an opiate. At first it was heroin, but now he's dependent on methadone. Second is that because the patient is still on an opiate, which is a depressant drug. So if the patient were to take some other depressant drugs such as alcohol, benzodiazepine, so the side effects would add on. So the patient may get unconscious and get into problems of having excessive depressant drugs. And the methadone program or the methadone therapy has been successful in reducing the number of heroin addicts. Well, now we come to the last drug that is used to treat opiate addiction, and that is the drug Naltrexone. The purpose of Naltrexone is to prevent patients who have already gone through withdrawal from going back to opiates. How does it do that? It does that by the fact that it is an antagonist of the opioid receptors, reversible antagonist, with the highest affinity for the mu receptors, but also having some affinity for delta and kappa receptors. So once we take an antagonist drug like that, it means that if we were to take an opiate agonist drug, we will not feel the effect of those agonists because our receptors has already been blocked by a high concentration of opiate antagonist drugs. There are three possible uses for naltrexone. The first is that this is the final step in the treatment of opiate addiction. So we already have the patient stabilized on methadone, and then we get the patient to be off the methadone. So now the patient is no longer taking methadone, and we're going to use naltrexone to prevent the patient from going back to opiates. The other use is that if the methadone program is not available, then naltrexone can be used to discourage patients going back to opiates. And lastly, for patients who cannot join the methadone program, for example, some workplaces do not allow their workers to be part of a methadone program, so then those patients can take naltrexone as a way to prevent themselves from going back to opiates. So the way naltrexone is taken is that it is a once daily tablet. The patient takes it once a day. So the question I want to ask is that if the patient wants to feel the effects of opiates again while having naltrexone, how can he do that? How can he gets back the euphoria feeling of opioid agonist once again if he wants to? How does he do that? So the best candidate to use naltrexone is a person with a stable setting and a very high motivation to not to want to go back to opiates. For example, people who work in the hospital who has access to the opiate drugs, so they do not want to go back to opiate drugs, they want to keep their job. So these people would be disciplined and would be highly motivated to take naltrexone so that they do not get tempted to go back to opiate addiction once again. The side effects of naltrexone are fairly minor. Commonly there could be gastrointestinal side effects such as nausea or diarrhea, or some patients may get dysphoria, sense of being uncomfortable, or in high doses some patients may get liver toxicity, so they may need to do liver function tests before starting and also on a regular basis. And some precautions for using naltrexone. The first thing is that since naltrexone is an antagonist, so to avoid withdrawal symptoms, you want to make sure that the patient does not have any agonists in his body before giving naltrexone. So therefore, before starting naltrexone, it is good to make sure that the patient doesn't have any more opiates in the body, and so usually their opiate agonist should be stopped for a period of 7 to 10 days, depending on the half-life, to make sure that there are really no more opiates in his system. And just to make sure that there's really no more opiates, before taking naltrexone, the patient can be given a test dose of naloxone, another antagonist, and see if injectable naloxone can produce non-withdrawal syndromes in a very short period of time. And if there's no withdrawal symptoms, that means that the patient is all clear to start naltrexone. And finally, some precautions for users of naltrexone. So once they are taking naltrexone and antagonists, it means that if they were to take a normal dose of an opiate agonist, they might not feel anything. So if they have a medical need for opiate agonists, then they might need higher doses than normal. But if they get higher doses, there is a risk of side effect of respiratory depression, so need to be very careful. So usually patients on naltrexone will need to carry a badge or a card with them to inform healthcare workers that they are taking naltrexone. Well, now we want to consider why is naltrexone suitable for this purpose of preventing patients from going back to opiates. Why not use naloxone? Because naloxone is also an antagonist just like naltrexone. So to answer this question, why is naltrexone better than naloxone in the use of preventing people from going back to opiates, we need to look at especially the pharmacokinetic features of these drugs. So let us think about the pharmacokinetic features of naltrexone versus naloxone and decide why is it that naltrexone is more suitable. And here are the drugs that we have to know. Starting with the full or strong agonist, we had morphine, methadone, pethidine, and fentanyl. And moving on to the partial agonist, we saw codeine and buprenorphine. And then the mixed receptor agonist, example was nalbuphine. And finally for the antagonists, we had naloxone and naltrexone. And then we have to know all the listed adverse effects, because these are the most important ones. And so the adverse effects of opiates include euphoria, sedation, respiratory depression, myalgia, constipation, and pruritus. And then we know that use of opiates is also associated with two things, which is tolerance and dependence.
There's aspirin, adrenaline, and also aminophylline, amphetamine, adenosine, augmentin, and rifampicin, amoxicillin, penicillin, heparin, and warfarin, and estrogen, progestogen, and canesten, and chloroquine. There's bendraflumethiazide, and also cyclophosphamide, and metoclopramide, acetazolamide, tropicamide, loperamide, amiloride, and cyclizine, and fusamide. And if you're up the duff, then you'd best avoid thalidomide.